Hi, everyone. Thank you for joining us today for our Research in Progress webinar. Today, we're going to be talking about using global budgets and multi-sector teams to align systems in Vermont with Dr. Atherley and Julie Parker. I'm going to be your moderator. I'll host the Q&A after the presentation, and I'm going to pass it off to Dr. Atherley and Julie Parker to give us a description of their background and introduce the program.
Great, thank you very much, Dina. Let's see, let me share my screen. Okay, so our topic today is, as you said, the impact of global budgets and community health workers on health, health equity, and cross-sector interconnectedness in Vermont. We have a pretty large research team working on the project overall. The key people on this particular question that we're asking are myself, and I'm a health services researcher, health economist at Virginia Commonwealth University. Alina Vandenbroek-Altenburg, who's also a health services researcher, health economist, but she's at the University of Vermont in the Department of Radiology. And then Jamie Benson, who is who's been the research associate on this project. We are also joined by Julie Parker, who's at the Blueprint for Health. And again, she's a licensed mental health counselor and a certified case manager. She worked as a psychotherapist and a crisis clinician. And she's been just sort of over the last year, kind of the key person who's been our liaison with the Blueprint for Health and with community health teams. So she works really extensively with the community health teams, and she's sort of really helped us, and as I'll describe as we go through the project, sort of in all aspects of our project, from forming the questions, contacting people, getting follow-up, and understanding the data. And so she's going to be here to talk about her view of the results of the project as well. Okay, so the purpose of the project is we're trying to evaluate the effect of combining a global all-payer reimbursement system with community health teams who are responsible for coordinating care and service delivery between the medical, social service, and public health sectors on system alignment, health, access to healthcare, and health equity. The setting for our project is the Vermont all-payer model. And 5 years ago, the state of Vermont received a waiver from CMS, from the CMS Innovation Center, to allow an all-payer ACO. So how is an all-payer ACO different than what we usually see? What this did is it'll let funds flow to the ACO from Medicare, Medicaid, and commercial insurance and Medicaid via state law, Medicaid via the waiver. And all the money flows to the ACO. The ACO then is a position to turn around and finance healthcare in a different way. So there's all kinds of innovations that they're able to do in terms of the payment mechanism. For example, most of the hospitals now are on what is effectively a capitated system. So rather than being paid for traditional fee-for-service for ACO enrollees, they actually received a fixed monthly payment for all necessary services. They've also done all kinds of innovative things in the community in terms of how they pay primary care practices, with maybe the most extreme version of it being that some primary care practices are actually receiving geographic capitation for providing primary care for people in their area. So there's just, and the idea here is to really try to shift the entire healthcare system away from a volume-based system where the more you do, the more you're paid, to a value-based system where you're rewarded for keeping the population healthy. And this reform then is sort of the layered upon previous reforms in the state of Vermont that had already established regional community health teams and primary care medical homes for everybody in the state. There's been some analysis by NORC of the waiver, and overall, the early returns on it are quite favorable. It appears to be being successful in terms of bending the cost curve, and it also appears to, in the preliminary data, be doing a good job in improving the population health. So the community health teams that are referred to are, there's a statewide network of regional community health teams. So Vermont is divided into 13 health regions, and every region has a community health team. And the community health teams are relatively unstandardized. So they've been in place for more than 10 years, and they're funded by the Blueprint for Health, which Julie Parker is a representative of here today. And the Blueprint for Health, traditionally what they've done is they've essentially just sent a lump sum to the community health teams, and then allowed the community health teams a lot of flexibility in terms of the types of services they deliver, the types of populations that they prioritize, the types of expertise that they want within their community health teams. So there's a lot of heterogeneity across the state in terms of what the community health teams are doing and what they look like. One of the things community health teams do is, again, they support the patient-centered medical homes, which is standardized across the state. But then beyond that, there's a fairly long list of kinds of things that they've been doing. And the community health teams are very, very connected within their local communities. So they work with their community partners to try to identify priorities for what they want to do to improve the health of the population. So the community health teams then end up being in sort of an interesting spot, because on the one hand, the Accountable Care Organization and the statewide waiver is trying to really shift the focus of the state onto population health. At the same time, the community health teams have this long-standing connection into their communities and what they're doing with primary care homes. So what you hope is that this all-payer waiver is going to create an alignment between what's happening in the healthcare sector and what the community health teams are doing in the public health sectors and social service sectors. But there's also potentially, as you look at this, a little bit of tension, because the all-payer waiver is really a statewide initiative, whereas the community health teams are really focused in their local communities. So the research questions then that we're asking here is, we want to understand how the community health teams think about this. We want to understand how they set their priorities for what kinds of services to offer, and how they think about the trade-offs, because again, for the community health teams, there's sort of an unlimited number of health needs within the community. So they have to make some choices in terms of what are their priorities. So we want to understand how they think about what they're doing in terms of health, healthcare spending, health equity. And then we want to understand, when this all-payer model then comes in, does that help to create alignment for the community health teams with other sectors of the health delivery system? The first thing that we did to do this is we wanted to identify the contextual factors that allowed to allow the development of our attributes for discrete choice analysis, which I'm going to talk about. And then the second piece, which is really our focus today, is to try to estimate how these community health teams make trade-offs in priority setting using a discrete choice experiment. So the previous presentation we did about a year ago, we talked about how we identified the contextual factors. And what our team did, led by Lisa Nankin, is went out and, well, actually didn't go out, but sat in the office and via Zoom had a conversation with every community health team in the state. And so we asked them to talk to us, and then we did an analysis of those results to try to identify the key factors in terms of how they made their decisions and set their priorities. And this was sort of the end of what we did last time in terms of what we heard from the community health teams in terms of how they thought about the Blueprint for Health, the statewide ACO, which is called OneCare, and how they think about their priorities. And what the four major themes that came out of our qualitative analysis of the interview data is that the community health teams put a huge value on Blueprint's stable and flexible structure, that Blueprint would give them money every month and let them have a lot of flexibility in terms of what sorts of services that they wanted to deliver. And they felt like that really gave them a good opportunity to prioritize the needs of their communities. We also heard that care coordination was a big priority for these community health teams. Again, given their history in terms of the primary care medical homes, that made a lot of sense, but trying to really help coordinate care for individuals, particularly individuals with chronic illnesses, across different sectors of the healthcare system and the social services and public health systems. They also worked a lot with their community partnerships and their local resources. So they tapped into the local community networks and they worked with their community networks to prioritize the needs of the communities. And as an example of that, one of the community health teams was in an area which had no services at all for persons experiencing homelessness. And so that then became a priority for the community health team, because that was a gap within their community, and that was a priority for members of their community. And then the fourth theme that we heard is that the community health teams really wanted more data, and they really wanted to use data to set their program priorities and do data-driven decision-making. But they were in a place where they didn't really have good data from they really want to know what was going on in their communities in terms of the health needs, but they really didn't have good data from anywhere that would sort of help them prioritize based on the data in terms of the health needs of their population. They're really more dealing in a world where they're sort of, they know what's going on statewide, and then they're sort of talking to people anecdotally and trying to identify the priorities without the systematic data. And the data is something that they very much wanted. So for the second piece of this, then we want to understand how they set their priorities and how they think about the trade-offs between different programs that they could offer. And the methodology we used is what's called a discrete choice experiment. So this is a quantitative approach to elicit individual preferences. So the idea here is that we can use revealed choice models to try to understand how people make choices when they're presented them. But what we want to do is we want to understand how they make choices with hypothetical alternatives that may not exist, but could. So if you think about, you've got the programs that you're offering as a community health team, but there's a whole bunch of other programs you could have offered instead. So if you had to choose between, say, the program you offered and some other alternatives, how would you make that choice? And what would be the priorities in terms of the attributes and the levels of the programs that would lead you to make a choice? So what we do is we take choices, and then we characterize the different choices that the community health teams could make based on the attributes and the levels of the choice. And so the attributes are choices of the characteristics of the choice, and the levels are the values. So if you think about buying a car, for example, an attribute would be color, and a level would be red, blue, green, white. And so the idea is that when you pick your car, you're going to look at the color and the different levels of cover, but you're also going to look at other features. And we want to understand how the different attributes and levels influence choice. So based on our qualitative interviews, there were 5 key attributes that seemed to be really important to the community health teams as they think about their choices. The first is who the program champion is. So who is it that's really advocating for this program? The second is funding opportunities. So a lot of the community health teams, they have the stable funding from Blueprint, but they're also writing grants on the side, and they're looking for other places that they can find additional funding to offer additional programs. And so they would prioritize programs where they thought they could essentially get money to support themselves. Who the target population is mattered a lot. And for example, the homeless population I mentioned earlier might be a priority for the community health teams. Whether or not it's in the community health plan was really important, because again, the community health team plan is being written by the community as their health priorities. And for the community health teams who are participating in that process, in many cases, that's a priority for them. And the fifth is the availability of data that shows whether or not the program is effective or not. So that gave us our attributes. The levels were identified through a combination of interview responses and expert opinions. So as we characterize the choices, then these are the attributes and levels that we put in. The first was the cost of the program, which could be $50,000, $75,000, or $100,000. Who is advocating for the program, and that could be patients, primary care providers, local hospitals, community partners, the Blueprint for Health, or OneCare, which is the all-payer ACO. The level of data that supports the effectiveness of the program, which could be no data, anecdotal data, or quantitative data. The population which is affected by the program, which could be the general population, racial and ethnic minorities, persons experiencing homelessness, people who are economically disadvantaged, people with severe chronic health conditions, or people with substance use disorder issues. The population size and effect. And so that would be a small population and a large effect. So we gave examples of this. So a small population, large effect might be, for example, a program targeting people with multiple chronic conditions. So a small group of people, but you'd have a very substantial effect on their health. You could have a medium population, a medium effect, or a large population with a small effect. And our example of a large population and a small effect was, for example, improving the walkability of a community. So that would affect a lot of people, but it wouldn't have a huge health effect on any one individual. And then whether or not it was in the community health plan. So the way that we do this then is we provide each respondent choice alternatives that vary in the attribute levels. And then what happens is you see a survey and you sort of say, all right, and I'll show you an example in a moment, but you say, here are 3 alternatives. Which of these alternatives would you prefer? And then we repeat that task multiple times. The way that this works mechanically is, if you think about those levels and attributes, this is sort of a factorial design. So if you think about all the possible combinations of all the different attributes and levels, there's about 2,000 possible combinations of attributes and levels. We obviously can't ask people to complete the survey 2,000 times. There's iterative computer search algorithms that can identify efficient designs, and they can do things like eliminate dominant choices. If one choice is clearly better or clearly worse than another choice, that gets eliminated. And then once it'll sort of narrow it down to the best choices in terms of being able to identify the factors that drive the decision making. And then we run a lot of standardized checks to make sure that people are making consistent choices within the data. We sent it, the way we then what we did is we built this survey, and again, I'll show you an example in a moment. Then we sent this survey to every community health team in the state of Vermont. That was done between February and April of 2022. And Julie was the key one who was the liaison there. She sent out the emails warning them that this was coming, and she encouraged them to complete it. We included both the leadership and team members in this. Each discrete choice experiment had 3 choices with the 6 attributes I showed you. We asked people to complete the choice task 14 times. We got 180 individual responses, which gave us 2,520 completed choice tasks. So they got the introductory email, they got some reminder emails, and this was all done online. The survey design, so first they were asked to give us some sociodemographic information, tell us about how many years they'd worked in the field, their professional background, their gender, their age, that kind of variable. And also we asked them to what extent they felt they had priority control over the priority setting for their community health team. And then we had them do the choice tasks. And then the third part, we asked them if there was any attributes that they ignored as they made the choices, and then made their choice in terms of which attributes they thought were the most important. So the way this works then is you get the survey and it gives you a little orientation to the project and attributes, and then you get this vignette. And it says, for the purpose of the study, suppose you're in a position to decide the next program for your team. You're receiving $100,000 in new funding for one of 3 new programs, which vary in cost. All the programs are equal in terms of administrative complexity, and each of the programs has strong evidence for their effectiveness. Any funds left over at the completion of the program may be kept by your community health team to support other programs. The new programs differ in the following ways. And then what they would, then you get the description that I just gave you a couple of slides ago. And so then this is what it actually mechanically looks like as you're filling out the survey. You have option 1, option 2, option 3, and you can see they vary in cost, the population size and effect, the levels of data supporting the need, the partner who's advocating, and whether or not it's in the community health plan. The idea is what people will do is then read through these 3 options, and they say, well, if I were making the decision, this is the choice that I would make. And then once we have that data, we can then essentially model the choices and see what the effect of different attributes and level is on the probability of choices. We did this using both a mixed and a conditional logit model. So the mixed logit model doesn't have the assumption of IIA, which is one advantage of it. And the other thing is we're really interested in letting the taste coefficients, which are the betas, be random. So we can essentially understand variability in the coefficients as well. So we can understand if different people responded differently to the different initiatives. And then, okay, the results. So this is what our population looked like. So it was mostly female, so 88% female and only about 12% male, which is just reflects the nature of the community health teams. On average, they were 47 years old. They've been working in their job for about 5 years. We asked them on a 1 to 5 scale whether they had control of the priority setting and the funding allocation. And in general, people felt like they had a little more control over the priority setting than the funding. And it took people about 2,000 seconds to complete the survey. This is what the sample looks like. So we got, we just got a terrific variability in terms of the types of people answering the survey, including both leadership, community health workers, and a whole bunch of different professions. What this is a violin chart, and this shows you the mean and the distribution in terms of people's rating on which of the healthcare services were most important. So essentially what this said is this takes 9 different attributes and says what's the most important and what's the least important. And you can essentially the longer if you get the ones that sort of look like little tadpoles, that suggests a tighter distribution, and the wider it is, the more variability you get in the responses. But you can see the number 1 priority for the community health teams was helping vulnerable populations, and then the number 2 was managing chronic conditions. The lowest priorities were nutrition counseling and reducing healthcare spending. This is the attribute importance. And again, the number 1 attribute in terms of just the ratings was the population affected, followed by the population size and effect. And in this, surprisingly, the lowest important was whether it was in the community health plan, kind of tied with the partner who's advocating for the idea. And in terms of the information source, the most important information source was local primary care reports, followed by patients. And the least important were Blueprint reports and OneCare reports. So when we put these choices in the conditional logit model, what we found is that, so what I've got is I've got the variables on the far left. So cost, the population affected, the population size and effect, the data supporting the program, the group advocating, and whether it's in the community health plan. And then on the far right is the reference group for each of these models. So, and then I've got stars for the statistically significant. So in terms of the population affected, the reference group was the general population. And there was a preference for programs that targeted persons experiencing homelessness. And there was actually a negative coefficient for on racial and ethnic minorities, which was contrary to our expectations. And none of the others were statistically significant. In terms of population size and effect, the reference group was a small population and a large effect. And there was no statistical difference between that reference group and the medium population moderate effect. But there was a negative and fairly large coefficient in terms of large population and small effects, which suggests that the community health teams were more interested in programs that either had a small population with a large effect or a medium population with a moderate effect. In terms of the data supporting the program, there was a very strong preference for quantitative data. And again, if you look at the coefficient of 0.13, it's very statistically significant with a big T statistic and a fairly large coefficient. So that was a big effect in terms of the choice of the program. In terms of the group advocating for the program, the reference group was the Blueprint for Health. And that was, none of the other groups were statistically different from Blueprint for Health, with the exception of OneCare, which is the all-payer ACO, where there was a negative coefficient. And finally, there was a strong statistically significant positive effect for whether or not the program was in the community health plan. The mixed logit models were, I showed you, those are conditional logits. The mixed logit models were consistent with these results. Which might be largely because of IA wasn't a problem. none of the interaction terms that we tested were statistically significant, which very much surprised us. And we looked at a whole bunch of different factors. So for example, we thought that people with a patient-facing role may prioritize different populations differently, and that did not prove to be the effect. We also thought years of experience would predict the kinds of programs prioritized, but that was also not true. We looked at a number of different community factors like ED use rates within the community, housing issues within the community. None of that was statistically significant. And then the last one is we thought, I thought that the leadership would care a lot more about the cost of the program than people who were not in leadership. And in fact, that was not the case either. And in fact, when we compared the leadership to the staff preferences, this is where people are ranking this is a ranking of the importance of the information sources and the attribute importance in terms of 1 to 7. So 1 being the most important and 7 being the least important. And what I've got is the median numbers there is if you compare the rankings of the staff and people in leadership roles, there's very little difference in terms of the priority setting between the staffs and leadership roles. So what we concluded is, the first obvious conclusion is that the community health teams prioritized programs that were in the community health plan. And they did not necessarily prioritize programs that were championed by the all-payer ACO. They also supported programs that have evidence of effectiveness and especially good data to support the effectiveness of the program on the population. And they prioritized populations targeting persons with experiencing homelessness. And again, there's a strong desire and willingness to use data. And there was excellent alignment within the community health teams on the priorities for the community health teams. So rolling that up then, the new all-payer model doesn't necessarily automatically create system alignment. And there's actually, if you look at the data, there's a fairly clear logic to it. The community health teams, and I'm actually, Jamie Benson was the one who came up with this characterization of our data, which I thought was just terrific, that the community health teams really prioritize local needs and local voices. And the statewide priorities are much less important. And so you have this really good alignment within the community health teams. And so there's kind of somewhat of a disconnection between what the state goals are and the community health systems goals, especially since the state is negotiating with CMS, the Innovation Center, and they have all of these fairly rigid targets in terms of things like cost reduction. And that's just not a priority for the community health teams. So there's a little bit of a misalignment there, but it's also not completely misaligned because the population that's most prioritized by the community health teams are people with chronic illnesses. And obviously, if you're trying to control healthcare spending, populations with multiple chronic illnesses would be the obvious place to start. So there's not an automatic alignment, but there's also not sort of there's a lot of, given that both the ACO and the community health teams really want to help people with lots of health problems stay healthy. Although maybe the motivations are different. One wants to save money and the other wants to just do it because that's their mission. That creates some degree of alignment. But if you really want to improve alignment, there's sort of 3 things that really jump out from this data. The first is to have a consistency between the statewide population health goals and the community health plans. That you have each of the communities working with their local hospitals to write the community health plans, and then you separately have the state negotiating with the Innovation Center for the statewide goals. And an effort to align those two would do a lot to create alignment within the system. So if you can get the community health plans and the negotiated statewide goals to be aligned, that would help a lot. The second problem is the commonality in the covered populations. The community health teams put a great value on the fact that they help whoever needs help. You walk in their door and they're going to help you. And the funding from Blueprint is not tied to service delivery. It's just a lump sum that they get to work with their communities to try to make people healthier. So if you have needs, they're going to try to help you. The ACO has a covered population, and they've got all kinds of targets for what percentage of the population they have to cover and so on, but it's really only half the population at this point that's enrolled in the all-payer ACO. So when you think about, for example, homeless population, that's a big priority for the community health teams. They're very unlikely to be enrolled in the ACO. So there's a disconnection between the populations where the community health teams are much broader, and the ACO just by design is focused on their covered population. As more and more of the population becomes covered by the all-payer ACO, then this problem will diminish over time. But that does create some degree of tension right now. And then finally, common data on the program effectiveness. You know, the message we got on the qualitative interviews, the message we see in this data is just really, really consistent that the community health teams would like to have data in terms of what the health problems in their communities are, and data on what sort of interventions are most effective to help people stay healthy. So the ACO is in a fairly good position to potentially help provide some of that data. And so if you can get some common data across the state in terms of the kinds of programs that are most effectiveness and the needs of the populations, that will again just sort of create a natural alignment between the statewide goals and the community goals. In terms of our next step, we have a couple of manuscripts that are under review at this point. We also worked with we've worked with the ACO to understand how healthcare providers are thinking about this. So we've actually put a provider engagement survey out that we're analyzing this. And, you know, when you start talking about, people talk about changing the healthcare system from a volume-based system to a value-based system, it is very difficult to really change. You know, the volume-based system is so embedded in the healthcare system in the US. It's very difficult to change that. And so providers are struggling with this just as much as the community health teams are. And then we're in the process of getting 2 more surveys out. One, we're working with OneCare to do a provider survey, and then we're working with Blueprint to develop a second discrete choice experiment to understand how to better support the community health teams. And then my acknowledgements are, again, obviously funding from the Robert Wood Johnson Foundation and the Systems for Action Initiative. So thank you very much. And we did this in partnership with the Blueprint for Health. We could not have done this work without them. And we've also, we've presented the results of this to Blueprint of Health leadership and also to the community health teams. And we've had a lot of just terrific feedback from them. I'll also say we presented results of this to the leadership of the statewide ACO, and they also had some just terrific things to say to help us with this. These are obviously preliminary results, but they're not very preliminary. They're pretty close to final. And finally, you know, if I said anything that was wrong, that's on me and not on Blueprint or OneCare. Okay, thank you very much. Julie, now it's your turn.
Okay, great. Let me just share my screen here. 1 second. And hopefully everybody can see that. Can everyone see that? I'm going to assume yes. Let me, hold on 1 second. Sorry, everybody. Hopefully everyone can see just my one slide. I'm Julie Parker. I'm one of the assistant directors of the Blueprint. And so I'd like to just kind of share a little bit from the ground perspective and to make the connection with the research that was done. So, you know, as Adam talked about our ACO model, and I'll touch on a little bit of some of our priorities here for our community health teams, is ensuring that we have good access to primary care. We can decrease deaths due to drug overdose and suicide, and reduce the prevalence and morbidity of chronic disease. So those are 3 key areas that we put forth in the all-payer model within our communities. And this is just sort of a little organization way that we think about how we take our payers and how we build on what we call advanced primary care and our integrated care model foundation. So,
hey, Julie, I don't think you're showing the slides you intend to show. We're still seeing the, we're not seeing the slideshow. We're just seeing the.
What are you saying?
we're seeing all of the slides kind of on the side, and then we've got the.
Okay, let me try again. Now?
That's it. Yep, exactly right.
Okay, there we
Sorry to
go.
interrupt.
No, I'm glad you did. Thank you so much. Okay, so I don't think the slide, or do you, I apologize. I'm moving my slides, but they don't seem to be moving. Here we go. Do you see a bunch of squares?
We see squares, yes.
Okay, there we
Yes.
go. So okay, perfect. So I just wanted to comment on who mostly makes up our community health teams. And primarily we have our nurses, our mental health clinicians, case managers, care coordinators, panel managers, dietitians, community health workers. So that tends to be the core of our teams, and their titles. They could be mastered and bachelors, and just really, really depends. But generally that's who makes up our community health teams. So one of the things that Adam obviously touches on, and I want to ensure that we talk about, is just, what is important to our community health teams. And I think, in the results that Adam showed, we see some of that, but they want to ensure, and we want to ensure, that we're serving all folks, not just the attributed population. That, again, as anybody who comes in the door and who needs support, we're able to serve. Coordinating care is really key. Working with our community partners, ensuring that folks are getting to the services they need. Screening, interventions, referral to services, and treatment is really key. Whole person health, which we'll talk a little bit more in another slide. Making sure we're connecting with patient goals and empowering folks to manage their own health and wellness with the support of the community health team, but ensuring that we're also addressing people's personal choices and meeting people where they're at in terms of their wellness goals. And there's a patient experience survey called the Consumer Assessment of Healthcare Providers that goes out. It's actually out right now for patients to fill out. And we actually did kind of a news broadcast clip, our executive director, and talked about really the importance of why we ask folks to fill this out and to get results, so we can really understand folks' experience in terms of accessing care, being referred to specialty care, interaction for mental health needs or other whole health needs. So that's one thing we share once there's results of that. And so folks can hear that and understand more. How are patients perceiving and experiencing their care? So the linkage to the community is really important. And again, the unique thing is every community is a little bit different, but mostly every community has these types of services that folks use, and referrals are made or supports given to get to our designated mental health agencies. We have a special chronic care initiative that works with folks across our state, VNA, home health, peers, food shelves. So just a note of, it's important to think about, yes, we have a community health team that's embedded within our patient-centered medical homes, but there's a whole community in each community that impacts patients' wellness and working on their goals and improving their self and life. So I always want to note that, because I think it's so important to make sure that it does take a whole community to support each other. So one of the things, again, Adam mentioned, was what's called a community health needs assessment that hospitals need to do. And this is something that, again, the communities ask what's needed. And so the thing we want to look at are what are unmet needs and barriers to healthcare, which again, varies in different communities, but what's impacting, what are our community needs? So social determinants of health, medical, dental, housing, food, depression, trauma. Obviously in our more populated areas, there is a little more access to transportation. However, there are some areas that have no access to transportation or very minimal access to transportation. So that is one example that's going to vary. A community may have more dentists that take Medicaid patients or take certain types of insurance where other communities don't. And how do we access good dental care for folks, and how do they get there? So we're really looking at those needs, housing, all those things, reproductive health, mental health, like I said, the unique community needs. So that's something that comes to the table as well. And those goals may connect with our all-payer model goals or our state goals, but generally that's where there can be a little bit of disconnect, because we're trying to figure out in each community, are the larger goals meeting what people see in the community? So there can be, some interesting dialogue and conversation about that. So one of the things that we need to definitely be better at, and we're working on, is aligning and crosswalking our measures. So there are ACO measures, blueprint measures, and varying other measures, MIPS, MACRA, all the things the hospitals do, and that I don't know every single detail about. Also in Vermont, in order to be part of the blueprint, you have to be NCQA certified, and that makes you what's called a patient-centered medical home. So there's lots of things. So we built a spreadsheet that's our quality improvement facilitators are working on to align some of those measures to say, are we hitting the targets here? Is there overlap? Is there any way to adjust here so we're not duplicating something or something that's similar? So we're looking at all those. That's something our quality improvement facilitators do with our program managers in each of our 13 health service areas. Measuring the community health team impact, there's some challenges in that, in the sense that when this program was built, we're not supposed to be billing, which is fantastic for the patient. But we also can't capture how many encounters we may have, or how many, what we call, episodes of care we might be having with our community health teams. So, when the blueprint started, EHRs weren't fully operable, and now we're moving, more and more and more, and they're fully operable. And now it's really saying, how can we build certain things in the EHR so that we can capture CHT encounters? So CHT folks may, write notes, but how do we pull data from that? Or, how do we pull more information on the social determinants of health? So that's always a real conversation, and something that's continuing to build within our network on how we can capture more data around the community health team encounters. So work in progress. And again, the positive of that is we don't bill. So there isn't data we can pull from claims data, which we typically do for lots of other things to, show how many services are being done for X, Y, and Z. And then, how do we measure if someone's better off? So I'm a mental health counselor, and, I believe in data, and I know the importance of data, but I also got into this work to help and support people. And so it's not as easy as we know as, did their A1C go down? Yes, it did. Did someone lose weight? Yes, they did. Did their, triglycerides, right? That's sort of some measurable things where you can say health-wise, their health is improving. It's a little harder to measure social determinants of health. And so that's always, I think, a tricky part. We know anecdotally, we can say certainly people are better off when they're connected with support and guidance and community health workers and all those things, but it's not as easily measurable as perhaps some things. Again, you can sort of medically tick off that somebody's improving. So that's always again, another discussion of ensuring we're continuing to look at how we know folks are better off. The one thing the blueprint did for many years was community profiles, which we have not been able to do since 2018 for a few reasons. And we're hoping to reinstate those and making sure that goes forward. And so things that are on the community profiles that we provided were things around, how many ED visits, how much resource use is happening in communities, like example for MRIs. Why is this community, having thousands of MRIs when this community is not having? So we look at things like that. Eye exams for diabetics, different things that we're able to provide each community. So we're hoping 2023, we're going to be able to reinstate those community profiles, and that data is gathered from lots of different sources to be able to do that. As Adam said, timely and accessible data is key. We're always looking at ways we can use our payer data. And again, there's lots of other data sources. I'm not the data expert, but our data team is always looking at the different databases we have that we're able to provide information to our communities. And then, I think it's really important just to talk about the fact that we have our quality improvement facilitators in our health service areas, and we're always looking at continuous quality improvement. So evaluating things, planning, doing, study, act, right? That work is really key within our primary care offices, and our community health teams are really a key part of that work in trying new things, again, to improve the patient experience, the patient access, ways that we can integrate care within the primary care office. So That's really important work that we're doing. And that's a really brief thumbnail sketch in the time that I was allowed to speak. And I'm happy to answer questions about the community health team or our programming. And I can stop sharing screen maybe. 1 second. Yeah.
Thanks, Julie. That's great. I'm now going to share my screen. All right, I know we had a couple questions in the chat, so I'll go ahead, pull up some of those. Thank you both for your discussion. I thought it was really interesting. I feel like there's a lot that I don't know, but seems like you guys are experts in all of this, and it was very interesting stuff. So I think this one was for Adam. Janet Heinrich, do you plan to study the impact of teams on population health? And one of the ones she asks was substance abuse disorder treatments.
Well, I'll give a shot, and then Julie, maybe you could say a little, tell me what I get wrong or incomplete. So as Julie said, there's a really, we don't have good data in terms of what types of services community health teams are offering, or even really what their priorities are. I mean, they're given a tremendous amount of autonomy in terms of working with their populations. So if you don't have data, so there's you kind of can't do any of this. So I think for both the second question as well is to link the work of the teams with the payment model. Again, it's given that it's so difficult to measure what the teams are actually doing. It's not really possible then to link what the teams are doing to any kind of health or cost outcome. And I think that's one of the things we heard when we did the qualitative surveys is there was a lot of frustration with the ACO because they were actually asking the teams to put together data in terms of who's being served and what services are being provided. And the community health teams love the extra resources, but the extra work, that's a real change in terms of their structure. And the ACO, I think, discarded that system pretty quickly. So they listened to the community health teams, and they're trying very hard to figure out a way to work collaboratively with the community health teams because the goals should be aligned. But it's just you've got two very different organizational structures and expectations. I don't know, did I miss anything, Julie? What do you want to add?
No, yeah, I don't think so. I was just going to note, I mean, we have some additional programming that is considered CHT, but specifically around substance use disorder and also our pregnancy intention programming. But, we sort of work closely with Vermont Department of Health and their substance use disorder treatment programming. So they do our hub work for substance use disorder programming, and we do our spoke work under CHT. So, we have some data in terms of numbers of folks that receive services and different things like that. But, again, it's not impact, but more of who we can measure the impact in terms of numbers we're serving. But the outcome of that is a little bit trickier to digest and kind of put out there. So, yeah. Sorry, Unite Us is something that we are looking at. Above me, I know our Director of Healthcare Reform, Ina Backus, has met with some folks around that, and there are conversations around that. I'm not in depth involved in that, but I do know that there are conversations around that Unite Us platform. In terms of, done differently, for me, I think, so I come from an interesting perspective where I worked in the community as a lead of a community health team before I came to the state. So I'm going to go back to, I have always said I'd like to understand more of our impact, and is there a way we can measure that either within EHRs, or are there, I say, billing codes in a fake way, right? Like, are there codes that we can put in so that we're able to pull that back out? I think it would be interesting to see again, what I call episodes of care. How many times has somebody connected with the community health team? How many folks are we seeing? And then also correlating those with perhaps the reasons why. Like, what's the primary reason? Was it a social determinant of health? Was it a new healthcare diagnosis? Was somebody just had a heart attack or diabetes? So I'd like to understand that a little bit more. And we're finding ways to do that. But when I think back to the very beginning, as a person in the community, actually doing the work and saying, why didn't the state do this or that? So I have sort of both perspectives about things, and I can understand both sides too, but we'd like to be in a place where we could easier say to Medicaid and to our payers, these are our numbers and this is what it looks like in a better way. And we're working on it, but that's one thing.
Great. I actually had a question for Dr. Atherley. So you were talking about in the mixed logit model, some of the interactions, and I think the interactions were looking at attributes and levels. You said that it was surprising that they weren't significant, and I didn't, on face value understand why. Why would you expect those to be significant, and what's the importance of those interactions?
So the idea of the mixed logit is you can you're essentially letting the beta coefficients vary according to individual attributes. And so the idea would be, for example, the one I was most confident of was that the leadership would be much more concerned about the cost of a program than people who weren't in a leadership role. And again, that just wasn't the case. And then we thought that people, for example, who were, we took the different professions and we characterized them by whether or not they were patient facing or not patient facing. And we thought that if you think about the kinds of services and the kinds of populations that be prioritized, we thought the patient facing respondents would really have a different perspective in terms of what the most important problems were than the ones who weren't patient facing. And again, we didn't see that. We also, again, the other example would be years of experience where, we just thought that the people who'd been out there for a long time would have a different idea in terms of the kinds of things that really worked. And so they might have a really different set of priorities than people who were relatively new and maybe a little more, I don't want to say the word naive, but I can't think of a better one. But some people who are optimistic about their ability to make change as opposed to the ones who've been trying to do it for a long time. But we didn't see any of that. And I'm not sure if it was just, we had pretty good variability across on all the different elements, so I'm not quite sure why. Maybe they're just not different. Maybe it just doesn't. I mean, the thing is that when you look at the descriptive data, you actually see pretty good alignment across the team. So maybe it's just as simple as that. It's that there's just really isn't a lot of difference in terms of the preferences and priorities of the different people within the team.
Okay, that's very interesting. And then I also had a question regarding, so you were talking about, you now have these models that decide, or, how the community health teams make decisions about what populations they're going to target, what programs they're going to do. Wouldn't it be better if it was slightly different than what the ACO, waiver is targeting? Because then you'd get more broad coverage across the entire population. Whereas you were kind of like, oh, we should get the community health teams and the one payer waiver to be more aligned. To me, it seemed like it was, well, if they're both doing different things, more of the population's being covered. Did I misunderstand that? Or what's the motivation behind getting those two to be more targeted in their populations and programs?
Well, I'll give my response to Julie, and maybe you can
Sure.
see what you think about it. That, to me, when I talk to OneCare, that they're really all about population health, and this whole idea that they think a lot about the social determinants of health as well, and they have, under the waiver, in theory at least, they have the financial flexibility to say spend money in a different way. So they have put a fair amount of money into supporting the community health teams, and they can, for example, embed community health workers in primary care practices. You know, if it's more effective in terms of buying health to put a community health worker into a primary care practice than say a primary care physician, they actually have the financial flexibility to do that. And so given the structure of the community health teams, you know, building on that to try to do population health seems like it would make a lot of sense. And I think it does make a lot of sense, I think, from everybody's perspective. It's just a matter of there are, you know, I think hopefully when you saw this presentation, you'd say, oh yeah, of course, you know, you've got different populations. It wasn't obvious to me, at least in the beginning, that you'd have these sort of hiccups. And so in a lot of ways, what I'm hoping the value of this research, hopefully it's useful to OneCare, hopefully it's useful to Blueprint, but also just as other states think about moving to this system, you know, sort of pointing out the challenges. And as I say, OneCare in particular is working very hard, you know, once these bumps are identified, to try to get around them and really work with community health teams. But we're just trying to essentially almost document and show what the bumps are. So as other people move down this road, they can anticipate them more effectively.
Say one of the challenges is that the Blueprint pays up front, right? So we pay up front for folks to be embedded. The ACO pays after. And so, and there's some variability. You're unsure if you've checked all the boxes to get that payment. And so you can only then budgetarily wise hire so many people. So then you have a CHT team that needs to make sure they're doing everything the ACO asked because they want to get that payment, right? Their managers are saying, like, we have to make sure, as anybody, we need all of our dollars. And so there's the things to check off, but then there's 100 other things that are mattering to the community and to the people walking in the door. So you've got 15 people today that are unattributed that come into primary care and have a lot of needs. And I've got to help all of them. And so today I didn't hit any of those marks with the folks that I saw. And so that is a little bit of a balance of how the payment models work and how our care delivery works, that we do want to see everyone and we have to check boxes too. So it's, you know, it's just, it's a little tricky. So absolutely, in theory, you want to have everybody covered, but we also have to focus on X amount of things too. So yeah, that's how I'd answer that. Yeah. Yeah.
All right. I think maybe one more question from Paul. How is data shared between the service sectors, e.g. health, social, and education?
So yeah, that's a big question. You know, OneCare has some specific data they share with hospitals. We have payment data, or we have claims data we share around certain things. VDH has certain data points they share. So it depends on what it is, how we collect it, and how it can be spit back out. So I'm sorry, that's probably not the clearest answer, but there are different, certainly, ways data gets put in different platforms and then shared. And also, sorry, so hospitals can collect data too. They may be doing their own project around income, and then they share with the community, like, gosh, we have 50% of the community that's below this poverty line, and then so that means we need to do X, Y, and Z. So, you know, I think there's varying things, varying ways.
Awesome. Well, I think we're right at our 11 o'clock. Thank you guys so much for your talk. It was very interesting. Just some stuff for me to go through. If anyone would want a certificate for completion for today's webinar, it'll be emailed to you after the end of this survey. We have an upcoming webinar next week on Wednesday, October 26th, on connecting vulnerable seniors to nutrition assistance through a managed care plan. And we would just like to acknowledge Systems for Action, the national program from the Robert Wood Johnson Foundation in collaboration with the Colorado School of Public Health. Thanks, everyone.